This is a global prevalence of overweight and obesity in children and adolescents. We are having 41 million child less than 5 years old suffering from overweight or obesity, and more than 340 million young adults and child between 5 and 19 years suffering from overweight or obesity. And these are the causes of childhood obesity. They are complex and multifactorial. Genetic predisposition, endocrine disorders, psychological disorders, neurological and hypothalamic disorders, and drug-induced sometimes, and environmental. The environment is an obesogenic environment. And these are the stigma of childhood obesity. It is a disease and health issue. It's not just a shape or figure. According to the European Association for the Study of Obesity, they classify obesity in children as a chronic disease in children and adolescents, and it is crucial to increase individual and social awareness about obesity in childhood and in adolescence and how to intervene. According to the World Health Organization, childhood obesity is one of the most serious public health challenges of the 21st century. Overweight and obese children are likely to stay overweight and obese in adulthood. And according to Endocrine Society, pediatric obesity remains an ongoing serious international health concern affecting 17% of children in US and adolescents. These are some pediatric overweight and obesity complications and comorbidities. Those children and adolescents may suffer from pseudotumor cerebri, sleep apnea, early subclinical atherosclerosis, cardiovascular disease mortality, premature mortality in adulthood, dyslipidemia, pre-hypertension and hypertension, NAFLD, pre-diabetes or type 2 diabetes, hyperadrenogemia, polycystic ovary syndrome, proteinuria, focal segmental glomerulosclerosis, and some deformity in the joints. Some problems can occur in obese children, like we said, diabetes, high blood pressure, heart disease, stroke, sleep problems, liver disease, early puberty or menarche, eating disorders like anorexia and bulimia, skin infections, bronchial asthma, some respiratory problems, gallstones, sleep apnea, increased intracranial pressure, many complications, and overweight children are more likely to grow up as overweight and obese adults. Several types of cancers and osteoarthritis. Insulin resistance is a key pathogenic factor for both metabolic dysfunction associated steatotic liver disease. This is the new definition of NAFLD or MAFLD, metabolic dysfunction associated steatotic liver disease, and type 2 diabetes. The frequency of fatty acid is alarming in young adults, type 2 diabetes, and age, hemoglobin A1C with circumference, HOMA, are strong predictors of fatty liver. Some psychological disorders can happen also, like emotional disorders, psychological disorders, some harassment even from the family members or friends, discrimination, low self-esteem and depression. The role of adipocytokines in childhood and adolescent obesity, there is secretory role of visceral fats leading to pro-inflammatory cytokines in the form of interleukin-6 and the tumor necrosis factor, adipocytokines like adiponectin and leptin. These cytokines and adiponectin will lead directly to insulin resistance, and tumor necrosis factor and interleukin-6 are positively related to adiposity, hypertriglyceridemia, total cholesterol, and negatively related to HDL cholesterol in healthy adults. Adipocytes and macrophages embedded in adipose tissue overproduce interleukin-6. All these adipocytokines and inflammatory mediators are interlinked, and all will produce insulin resistance and will produce pathogenesis into fatty liver. This is the role, again, of adipocytokines, interleukin-6, tumor necrosis factor, will mediate lipolysis, leading to hepatic synthesis of fatty acids, and they will augment hypertriglyceridemia and increased level of fatty acids. Inflammatory cascade will lead to further hyperinsulinemia and insulin resistance. Interleukin-6 and tumor necrosis factor will act directly at insulin receptor, leading to insulin resistance. We come now to type 2 diabetes, and 1 in every 3 children born in the US after the year 2000 will become diabetic in the future, and this is according to the Center for Disease Control in 2003. Type 2 diabetes and use before 1990, only 5% of children diagnosed or adolescents diagnosed with diabetes were diagnosed as type 2 diabetes or classified as type 2 diabetes. But later on, they account for 30 to 50% of new cases of diabetes in use, and this parallel the national data of obesity, diabetes, type 2 diabetes in young adults, parallel the national data of obesity, tripling in rate during the past 20 years. And type 2 diabetes in young adults is considered #1 consequence of the epidemic of obesity. Children are becoming more sedentary, less physical education in school, more screen time. Only half of them get regular physical activity, and 14% of teenage do not do any physical activity at all. These are the risk factors for childhood type 2 diabetes according to Diabetes Canada, and we can find the family history of diabetes in the first or second degree relative, high risk races, obesity with BMI more than 95th percentile, impaired glucose tolerance, polycystic ovary syndrome, exposure to diabetes in utero during gestational diabetes of the mother, acanthosis nigricans, and some important cardiometabolic disorder like hypertension and dyslipidemia, fatty liver disease, and there is a new risk factor of the use of atypical antipsychotic medications. These are the clinical features at diagnosis of type 2 diabetes in young adults, and we can find obesity in 95% of cases, polycystic ovary syndrome in 12% of cases, dyslipidemia 44%, hypertension in 28%, and micro or macroalbuminuria in 14% of cases of type 2 diabetes in young adults. This is an important question. When and how to screen, and according to the AGA, we screen in children or young adults with overweight more than 85th percentile or obese more than 95th percentile who have one or more additional risk factor like family history, maternal history of diabetes, or gestational diabetes during the child gestation, a certain race or ethnicity, signs of insulin resistance like acanthosis nigricans, hypertension, dyslipidemia, polycystic ovary syndrome, or small for gestational age birth weight. Who to screen? Again, according to Diabetes Canada, in non-pubertal young adults having 3 or more risk factors beginning at the age of 8, or pubertal and 2 or more other risk factors, and among these risk factors is African and Arab races, and the presence of NAFLD proved by ALT more than 3 times upper normal, or fatty liver disease on ultrasound. Again, who to screen? Those with impaired fasting glucose or impaired glucose tolerance, and the use of atypical antipsychotic medications. How to screen? The recommended screening test, like in adults, using hemoglobin A1C and fasting or random plasma glucose. And if there is discrepancy between hemoglobin A1C and fasting plasma glucose, we should go to oral glucose tolerance test. Another important question: what are the associated complications and comorbidities in youth with type 2 diabetes? And we have short-term complications like diabetic ketoacidosis and hyperosmolar state, and we have long-term complications like severe and early onset microvascular complications in the form of retinopathy, neuropathy, and nephropathy. These are some comorbid conditions. Dyslipidemia, we should start screening at diagnosis of type 2 diabetes in young adults, and then we rescreen every 1 to 3 years. And we start management by trial of 3 to 6 months of a lifestyle modification, and if there is no improvement in dyslipidemia, then we should add a dyslipidemic medication, possibly statin. Some other comorbid conditions like hypertension, and we screen for high blood pressure at diagnosis, then repeatedly in every visit. And if hypertension is present, check other signs and symptoms of insulin resistance like polycystic ovary syndrome and non-alcoholic fatty liver disease. This is a screening schedule for neuropathy, to screen at diagnosis, then yearly screening. Retinopathy, again at diagnosis of type 2 diabetes in young adults, then yearly screening. For nephropathy, we screen by albumin-creatinine ratio at diagnosis, then yearly screening. Dyslipidemia by lipid profile at diagnosis, then yearly. Hypertension at diagnosis, then at every visit, and to take care of using an appropriate sized cuff. NAFLD, diagnosed by ALT or ultrasound, yearly, then at diagnosis, then yearly. Polycystic ovary syndrome, diagnosed clinically by symptoms, then by ultrasound. Obstructive sleep apnea by symptoms. Depression, this is important, especially in young adults with type 2 diabetes or with obesity. with the WHO screening for depression, binge eating by symptoms given by the patient. Young adults with diabetes have higher rate of cardiometabolic risk factors. This can lead to increased disease prevalence and mortality among those individuals at an early age. The presence of diabetes among youth and young adults will risk chronic complications at an earlier age and reduce life expectancy. These are some estimated morbidity and mortality in adolescents and young adults diagnosed with type 2 diabetes. We can find complications leading to early deaths, coronary heart disease, end-stage renal disease, and stroke. And those diabetes complications like nephropathy, stroke, coronary heart disease, blindness. So these are very risky, and we should take care of our young adults not to be diabetic, and when they are diabetic, we should take care of management. And how can we stop this cardiometabolic epidemic? This is the IGF recommendations for healthy lifestyle or healthy diet for all population, for the general population. What to choose for drinking, to drink water, coffee, or tea instead of fruit juice or soda. To eat lean meats, to eat at least 3 servings of vegetables per day and 3 servings of fruits per day. To choose nuts as a snack. What type of oils to choose? Unsaturated fats like olive oil, canola oil, corn oil, or sunflower oil instead of butter or other saturated fats. This is the WHO recommendation for physical activity in different age group, and in the young adults and children between 5 and 17 years old, they should do at least 60 minutes of moderate to vigorous exercise, vigorous intensity exercise on daily basis. How to prevent? By active play, by less TV viewing. The recommended screen time per day should be less than 2 hours per day according to the Center for Disease Control. More exercising and physical activity, healthy eating, weight loss, and medications. And this is the team approach between endocrinologists, physicians, and diabetes educators, dietitians, student himself, the family. The school has an important impact, and media. How do you initiate the change? School can provide quality physical education studies and increase the physical education classes and hours, nutritional awareness campaign, parent education awareness campaign, psychological education and psychological intervention when needed, and school nutritional policy. The main message: parents are an important influence on their children's eating habits. The main message: change will take time, begin by taking a few small steps. Thank you very much.
Thank you,